This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub Podcast. I'm Dr. Aris, Senior Attending Neurosurgeon, and today we're diving into the evolving landscape of interventional pain management, specifically focusing on alternatives to traditional epidural injections.
And I'm Dr. Elara, Research Fellow. Today we're looking at a fascinating new study from the journal Medicina, published in 2026, titled Cervical Multifidus Fatty Degeneration and Bony Foraminal Stenosis are associated with unsuccessful response to stellate ganglion block in cervical radicular pain, a retrospective study.
This is a timely topic. For our residents and colleagues listening, we all know the standard of care for refractory cervical radicular pain, pain radiating into the upper limb, usually caused by nerve root irritation, is often the cervical epidural steroid injection, or CESI. But CESI isn't without its catastrophic complications. We're talking spinal cord injury, inadvertent intrathecal injection, and anterior spinal artery syndrome.
Exactly, Dr. Aris. Plus, there's the radiation exposure for the surgeon and patient under fluoroscopy. That's why the Stellate Ganglion Block, or SGB, is emerging as such a promising alternative. It can be done under ultrasound guidance, avoiding radiation, and it targets the sympathetic innervation of the head, neck, and upper extremities.
Right. And while SGB is traditionally used for sympathetically maintained pain, this paper explores its use for radicular pain. The theory is that by modulating sympathetic overactivity and increasing regional blood flow, we can attenuate neurogenic inflammation by suppressing norepinephrine and nerve growth factor release. Since radicular pain involves vascular insufficiency and venous congestion, SGB makes a lot of sense.
It does, but as the study from the University of Ulsan points out, not everyone responds. They conducted a retrospective analysis to see if they could predict who would fail the treatment. They defined a successful response quite strictly, a reduction of 4 points or 50% on the numerical rating scale at 3 months post-procedure.
That's a solid clinical benchmark. If a patient doesn't hit that 50% mark, or if they require another intervention within 3 months, they were labeled an unsuccessful responder. So, Elara, what were the primary radiological markers they looked at?
They focused on two main areas, the state of the paraspinal muscles and the primary etiology of the neuroforaminal narrowing. Specifically, they looked at cervical multifidus fatty degeneration using the Goutleger's grading system and whether the stenosis was caused by a simple disc herniation or by bony hypertrophy, like unvertebral or facet joint changes.
Let's break down that first finding, the multifidus muscle. We often overlook the paraspinal musculature in our surgical planning, but it's a huge indicator of chronic pathology. What did the data show regarding fatty degeneration?
It was quite striking. They found that substantial cervical multifidus fatty degeneration, defined as a Goutleger's grade of 2 or higher, was independently associated with lower odds of a successful response. The odds ratio was 0.23. In plain English, if those muscles have significant fat infiltration, the SGB is much less likely to provide long-term relief.
That makes sense from a chronicity standpoint. Fatty degeneration of the multifidus is often a sign of chronic denervation or long-standing mechanical instability. If the pathology has progressed to the point of muscle atrophy and fatty replacement, a sympathetic block might just be too little too late. It suggests a point of no return in the local environment of the nerve root.
Precisely. And the second big factor was the primary etiology of foraminal stenosis. They compared patients whose stenosis was primarily due to disc herniation against those with bony hypertrophy of the unvertebral or facet joints.
And the results favored the disc patients?
Significantly. Bony hypertrophy was associated with an odds ratio of 0.35 for success compared to disc herniation. So if the nerve root is being compressed by hard bone, spondylotic changes, rather than soft disc material, the SGB is significantly less effective.
This fits the clinical profile we see in the OR. Disc herniations often have a significant inflammatory component that might respond well to the washout effect or the circulatory improvements of a sympathetic block. But bony stenosis is a fixed, mechanical narrowing. You can't unsympathize a bone spur.
Exactly. The study notes that bony hypertrophy leads to more rigid, persistent compression, whereas the inflammation from a disc might be more amenable to the physiological modulation SGB provides.
Now, let's talk about the procedure itself. Many of our residents ask if we should be adding steroids to these blocks. Did the study address the use of steroids?
They did. Interestingly, steroid use was not significantly associated with the treatment response. The odds ratio was 0.52, but the p-value was 0.223. This suggests that the sympathetic modulation itself, perhaps the local anesthetics effect on the ganglion, is doing the heavy lifting rather than the anti-inflammatory steroid.
That's a key takeaway. If the steroid isn't the deciding factor, it reinforces the idea that we are treating a vascular and sympathetic phenomenon. What about the cumulative effect of these risk factors? Did they look at what happens when a patient has both fatty degeneration and bony stenosis?
They did, and the successful response rate declined progressively. For patients with zero risk factors, meaning minimal fatty degeneration and a disc-only pathology, the success rate was a staggering 94.7%.
Nearly 95%? That's better than many surgical outcomes for radiculopathy.
It is, but once you add one factor, it drops to 50%. If the patient has both substantial fatty degeneration and bony hypertrophy, the success rate falls to 40.7%. The p-value there was less than 0.001. It's a very clear trend.
This is incredibly useful for patient counseling. When we're looking at an MRI in the clinic, we shouldn't just look at the level of the compression. We need to look at the type of compression and the quality of the multifidus. If I see a grade 2 gout-Leger multifidus and a massive osteophyte in the foramen, I might tell the patient that an SGB only has a 40% chance of working for 3 months.
And it might save them an unnecessary procedure and lead them towards surgical decompression or other options sooner. The authors really emphasize that these factors require prospective validation, but as a retrospective study, the correlation is quite robust.
It's also worth noting the safety profile. Throughout the study, they utilized ultrasound-guided SGB. For the junior residents listening, remember that the stellate ganglion is located at the C7 level, but we often perform the injection at the C6 level to avoid the pleura, allowing the medication to track down. Using ultrasound allows us to visualize the carotid artery, the internal jugular, and the longus colli muscle in real time.
Right, and the paper mentions that the SGB provides a therapeutic effect by modulating sympathetic overactivity and increasing regional blood flow. In the context of the multifidus muscle, it's interesting to wonder if the fatty degeneration is a marker for a nerve root that is already so damaged that its sympathetic tone is no longer the primary driver of the pain.
That's a sophisticated way to look at it. If the nerve is essentially dead or the muscle is already replaced by fat, you're not going to see much benefit from improving blood flow to that area. The neurogenic inflammation has already moved into a chronic degenerative phase.
To summarize the data for our listeners, if you're looking at a patient with cervical radicular pain for an SGB, check the MRI for gout-Leger grade greater than 2 of the cervical multifidus and look for bony hypertrophy at the unvertebral or facet joints. Those are your 2 red flags for failure.
Excellent. This study really highlights the move towards precision pain management. Instead of just throwing a block at every radiculopathy, we're using radiological biomarkers to predict success.
And it's a great reminder that the hub of neurosurgery is just the spinal cord and the nerves, but the surrounding architecture, the bones and the muscles, that tell the real story of the patient's pathology.
Well said. I think that's a perfect place to wrap up. Elara, thanks for breaking down the statistics for us.
My pleasure, Dr. Aris.
For our listeners, you can find the full text of this study in the June 2026 issue of Medicina. Join us next time on the Neurosurgery Hub Podcast as we continue to explore the cutting edge of our field. I'm Dr. Aris.
And I'm Dr. Elara. See you in the next episode.